Today I'd like to talk about suicidality and unintentional opioid overdoses in the United States. The rate of suicides and unintentional opioid overdoses has increased by 168% from between the year 2000 to the year 2017. In the year 2000, the rate was around 40,000, and in the year 2017, the rate was around 110,000. In the year 2010, the rate of suicides and unintentional opioid overdoses overtook the rate of death due to diabetes, suggesting that these problems are of epidemic proportions. There are two standard theories for the increase of suicidality and unintentional opioid overdoses over time. One is the demand theory and the other is the supply theory. The demand theory suggests that an increase in income inequality in the United States and a reduction in opportunities among working class individuals in the United States has led to an increase in depressive symptoms, an increase in the desire for opioids in order to cope with one's problems, and that increase in opioid use exacerbates the depressive symptoms, leads to opioid use disorder, ultimately leads to an increase in suicidality, and ultimately also leads to an increase in unintentional opioid overdoses. The supply side theory simply suggests that an increase in the supply of opioids in the United States over the past 19 plus years is associated with the increase is rather causative of the increase in opioid overdoses and suicides in the United States. We know that the average prescribed dose of opioids in the United States has increased from 100 morphine milligram equivalents in the year 1997 to 700 morphine milligram equivalents in the year 2007. Also, we know that in Australia, when the supply of opioids increased over time, the rates of unintentional opioid overdoses increased simultaneously. When the supply subsequently decreased on the intervention from public authorities, the rate of unintentional opioid overdoses also reduced. It is also thought that the supply side theory has more credence than the demand side theory. However, it is also thought that the demand side theory is a component of the increase in suicidality and opioid and unintentional opioid overdose increase within the United States over the past 19 plus years. So what do we as practitioners have in our arsenal to treat patients who have opioid use disorder? There are two options. One is psychotherapy and the other is pharmacology. In regards to psychotherapy, there's counseling and also self-help groups such as Narcotics Anonymous. In terms of pharmacology, methadone is the most commonly prescribed medication to treat patients who have opioid use disorder. It is a mu agonist that displaces the opioid that is currently in use, and it reduces withdrawal symptoms for 24 more hours, and it also reduces cravings for opioids over time. The problem with methadone is the small likelihood of overdose on the medication. And this is in contrast to buprenorphine, another option for the treatment of opioid use disorder. Buprenorphine is a partial mu agonist that also displaces the opioid in question, and the medication is not associated with an increased risk for overdose. Notably, buprenorphine is given in combination with the medication naloxone, known commonly as Narcan. The combination is given sublingually as a tablet. The reason for the combination is the fact that naloxone is not highly bioavailable when administered sublingually, and it is highly bioavailable when it is administered intravenously. So individuals who would like to abuse the medication by crushing the tablets and administering the contents intravenously would obtain a poor reaction, given that naloxone is a mu opioid antagonist that incites withdrawal symptoms immediately in individuals who have opioids in their system. Therefore, the combination is ideal for treating the opioid use disorder, preventing abuse, and it is notable that the combination is not associated with an increased risk of overdose as is methadone. After the treatment of opioid use disorder, naltrexone, a longer-acting mu opioid antagonist, is typically prescribed for maintenance therapy. And in individuals who are undergoing an overdose, naloxone again is indicated for rapid treatment and prevention of death. Naloxone again rapidly displaces the opioids in question, causes withdrawal symptoms, but ultimately saves the individual's life, who is the individual who is undergoing the overdose. That life is saved.